Welcome back to The Blend, a podcast brought to you by the editors of Journal of the Dermatology Nurse Practitioners and Physician Associates and the Dermatology Digest. In this episode, host Dr. Sonal Choudhary, director of the Integrative Dermatology and Skincare Clinic at the University of Pittsburgh Medical Center, sits down with Dr. Steven Daveluy, professor of dermatology and residency program director at Wayne State University School of Medicine in Detroit, Michigan, to discuss the dawn of personalized medicine and hidradenitis suppurativa. Dr. Daveluy also provides a sneak peek into the now-bustling HS pipeline.
Welcome to The Blend, the podcast where we bring together evidence, innovation, and thoughtful conversations to explore the evolving world of dermatology. Each episode features experts who are shaping the future of our field while sharing practical insights that clinicians can bring to patient care. Today's guest is Dr. Steve Daveluy, professor of dermatology at Wayne State University School of Medicine and residency program director for the Department of Dermatology. Dr. Daveluy is a nationally recognized expert in hidradenitis suppurativa, having contributed to numerous clinical trials, international consensus statements, and research initiatives focused on advancing care for patients living with HS. Not only that, he is also a passionate educator, mentor, and an advocate whose work spans health disparities, skin of color dermatology, and LGBTQ+ health. His commitment to improving both patient care and physician education has earned him numerous teaching and leadership awards throughout his career. Steve, welcome to The Blend.
Thanks so much for having me. I'm happy to be here.
Wonderful. So, Steve, you have spent much of your career caring for HS patients and helping advance the field. So I'm very excited to hear your perspective on where we are today and where we are headed. And we often talk about HS severity. So I want to dive right into it because not all severe HS looks the same, right? And how are you thinking about HS phenotypes today? I saw one of the papers that was recently published in the Journal of Integrative Dermatology, and I think you were the senior author on it. Correct me if I'm wrong, but I think I saw that. And do these different disease patterns, they require different treatment strategies according to you?
Yeah, it's a big topic in HS right now where we're sort of figuring out these different phenotypes. Because I think if you've treated enough HS patients, you can start to notice patterns and see that HS isn't always the same in everybody and it doesn't follow the same course. There's been some interesting research where they sort of take these massive numbers of HS patients, document all the features about the locations that they get the lesions, what type of lesions, and then they sort of have computer algorithms that cluster them and sort of clump them up. And so we're learning from that. The hard part is we haven't quite yet translated it into treatment strategies in terms of medications. But I think the phenotypes do help us understand what patients need more medical therapy versus what ones need a combination of medical and surgical therapy. And a lot of that is influenced by the tunneling. So if you start to get scarring and tunneling, that's the type of phenotype that's probably going to need more surgery. Versus if you have more of the abscesses and nodules, that's a phenotype that might respond really well to medications. And then there's some interesting ones. Like occasionally we get usually a young female who gets one tunnel in the groin, you cut it out, and then they basically don't have much activity after that. We get some men in their 50s and 60s who get new onset HS and it's really severe tunneling in the groin and the buttocks region. And they pretty much universally need surgery. But it'll be exciting to see as we figure these phenotypes out, what that means and how we can sort of tailor treatments to what's going to work well for someone as we keep sorting this out.
Yeah, and that does sound like moving towards personalized medicine, which in any chronic disease is pretty vital. And we're all trying to do that, build what works for the patient. I mean, the word biomarker also comes in mind to me there. And I know some people are working on that aspect of HS also. Okay, so once we have characterized the disease, the next challenge usually is deciding whether treatment is actually failing. And so many HS patients who reach a point where they feel like they've hit a wall with treatment. So how do you determine whether a patient has actually truly failed a therapy versus they need some kind of optimization of their current treatment plan? Like, what are the factors that you take into account there?
Yeah, that's the biggest challenge with HS is when you see the patient back and they're on a treatment and they have a partial response, what do I do now? Do I add to their regimen? Do I change something in their regimen? A lot of times in HS, we need combination therapies. So you look at, to get approval, a drug needs to reach the high score 50. So a 50% reduction in abscesses and nodules. And so a 50% reduction is not what we're excited about. We're used to psoriasis where it went from PASI 50 to 75 to 90 to now 100. And I hope we'll get there with HS pretty soon. But right now, the biologics tend to be partially effective, definitely more effective in patients if we can start them earlier. So that's one of the big things I look at is, did we get a partial response to this therapy or no response? And if it's no response, then we're going to change. If it's a partial response, then I usually am going to add to the regimen. So if they're on a biologic, we might add spironolactone or finasteride, sometimes short courses of antibiotics for flare-ups, metformin. Now the GLP-1s are have some emerging evidence that they can be useful in HS. So that's going to be something interesting to look at. Versus if a patient really either doesn't respond to a therapy and get significantly better, or if they respond, but then it kind of loses the effect. Sometimes with our TNF inhibitors, the patients sort of lose their response with time, and then it's time to move on. The other important point with this is to set expectations for patients, to let them know that, a partial response is still a success. We're just going to keep that medicine going and add to your regimen. I also like to warn patients that they might have a flare-up after we start a new treatment. It doesn't mean it's failing. They just need to pay attention to the flares. Are they less frequent? Is there more good days in between? Are they less intense? So that way your patients know not to sort of come in giving up on a therapy if they get a partial response too.
Yeah, I mean, we have so many more options now than we had some time ago. So I have a couple of questions for you there based on all you just mentioned. What is the follow-up period you usually have for your patients? I imagine it's a little variable depending on who the patient is. But do you have something that you 3 months or less?
Usually 3 months is pretty reasonable. A lot of the trials for HS drugs will look at the primary endpoint at 12 weeks or 16 weeks, so 3 or 4 months. We actually know, though, that the with more time, you get a better response. So a lot of times the studies show that treatments sort of start to peak and plateau at about 6 months. So I like to check back in 3 months. So that way I can see, are you getting a partial response? Are we moving in the right direction? Plus, you don't want to let things go too long if something isn't working. So 3 months is usually pretty good until you get the patient kind of stabilized and under control. And then you can space things out a little more.
And then with GLP-1s, you mentioned, I'm also seeing so many patients on GLP-1s, but my experience, and of course, I'm not recording this. This is not any study that I have going on right now, but with GLP-1s on board, is it in your observations, are you seeing a certain phenotype of patients who are responding better with their HS while they're on it, or it's very unclear course right now for you?
Yeah, I'm a little limited too. I've prescribed a GLP-1 once, but I haven't started using them regularly because I figured our office has enough prior authorizations already. I don't need to bring in a whole new class of prior auths. But I've had some patients who start them. And I've been pleasantly surprised where I have a patient that we've really been sort of struggling to get their HS under control or gotten them sort of to a good point, but not quite under control. Then they come back in and they're doing a lot better. And I say, what changed? And they had started a GLP-1. So for a lot of patients, I think it's beneficial. So like we said, there's very limited evidence now, mostly retrospective chart reviews, some prospective, but not really randomized controlled trials. But it looks like they can be beneficial, not only from the weight loss standpoint, but it looks like the GLP-1s actually have sort of a direct anti-inflammatory component as well, which is helpful for HS or even psoriasis.
That's where we are as well. But I wish I was making some kind of an observation from the beginning, but I think we can still start doing that. And among all the biologics we have available to us, the way I pick my biologics is mostly what the insurance will let me have. So it ended up being most of the TNF alpha inhibitors. And even with that, some of the original ones are now replaced by biosimilars, and we are seeing some more like, less response, more reactions with them. Do you have a better way of picking your starting point, more disease-based and patient-based than insurance-based, or do you have the same experience?
Pretty much the same experience. It's funny. I feel like anytime this comes up of how do you choose a biologic, everyone's answer is whatever the insurance tells me I can have. Sometimes you do get the, multiple options. Like for example, I practice in Michigan, and for the most part, we can get adalimumab or secukinumab first line, and then most of our insurances have bimekizumab sort of second line. When choosing between those, it's sort of like psoriasis. Sometimes it's based on comorbidities, or maybe if the patient has inflammatory bowel disease, I'm going to avoid a 17. Or if they've had a lot of problems with yeast infections, I might avoid a 17. Not necessarily a contraindication, but a relative one. And then with the TNFs, things like lupus, MS push you away from using a TNF. The joint pain piece is interesting, and there hasn't been a lot of work done on this, but sometimes HS comes with joint pain. So there's a question of, do the TNFs do a little better for the joints, or do the 17s do just as well? And I don't think we really know that yet. The joint pain in HS is vastly understudied, unlike psoriatic arthritis, because it's a little bit more of this mysterious comorbid joint pain that's not sort of a specific pattern the way that psoriasis is.
Wow, yes. Joint pains, it does make me wonder about any kind of neutrophilic disorders that often have joint pain associated with them. And the abscesses and the nodules of HS also have, of course, mixed inflammation, but neutrophils play such a big role. So that, kind of translates theoretically that way anyway. Documentation wise, are there any specific things, any kind of scoring systems that you document in a regular clinic that can make access to medications better and easier?
In terms of access, a lot of times it's sort of figuring out what the insurance wants to hear, right? Are they going to reject it if your note doesn't say that it's moderate to severe or that they failed certain therapies? So it's a little bit of learning, what your insurances want. We did do a little project a couple of years ago where we looked at a clinician reported outcome and a patient reported outcome that we thought were reasonable for use in clinic. Because as we all know, a lot of our clinical trial outcome measures just aren't reasonable to do, like the PASI. The high score you could maybe do in clinic. The trouble with the high score is that when we're counting lesions, we don't agree very well. And so some people call one thing an abscess and one thing a nodule, and it's hard to count. I'm sure you've seen an HS patient with really severe disease where it's basically taken over their whole armpit, and you're going, well, it's really hard to tell how many lesions are here because they're all sort of in one big mess, right?
Yes.
But the two we determined were for the patient-reported outcome, the HS quality of life tool, the HiSQOL, which is a 17-item quality of life that is specific to HS. So it asks even about drainage and pain that some of the other tools don't necessarily ask. Pretty quick to do. You can kind of incorporate it into your practice, either paper form or through your EHR, but it's a good way to get that patient information about how they're doing. And then the clinician reported outcome was the physician global assessment. And the reason we chose that is because you count lesions, but it doesn't matter if you tell what kind of lesion they are. They sort of all carry the same weight. So if you can't tell if it's an abscess or a nodule, that's okay. They're the same score, and you just add up the number, and then whichever's higher, the top half or the bottom half, is your overall score. And so we thought those were kind of convenient ones. I have one other I like to use in practice, which is the patient global assessment. It's a validated tool in HS that's really simple. You just ask the patient, in the past 7 days, how much impact has your HS had on your life? It's a great tool because it's one question, really easy, validated. So if there's one thing that I think people can sort of incorporate as an outcome measure, I think that's a good one.
That's great. And actually, as you were saying that, I realized that we have more like an observational thing where it's not a full study, but we are documenting some HSPGAs. We're practicing it, if anything else, and asking the patients about, well, in the last 7 days, how was the drainage or how was the pain and odor, right? Like these are all the components of the score. So we have been doing that. And at first I sometimes, you get a little hard time in a fast-paced clinic to document all these little things and ask so many more questions than we already do. But extremely valuable to have that, because next time they come back, this becomes a little more objective than just vaguely, just asking, are you better than before? So yeah, I absolutely agree. And we've been trying to use it. So one of the biggest shifts in HS care has been to recognize that medications are not only just part of the story, right? In the past decade, we've had all this medical therapy alone that was not always enough. So how do you decide when to incorporate procedures like de-roofing, laser therapy, surgery? Do you have surgeons that you collaborate with, that you refer to, like a specific team, or is it something that you do yourself?
For me, it's a mix of both. I do some procedures in the office. I have a CO2 laser that I can do. I do de-roofings and punch de-roofings and injections. But then some of the bigger cases or patients who can't really tolerate the local anesthetic as well, I do have a surgeon colleague. I think it's really important that you kind of communicate with your surgeon and work with them, because we have sort of led the field in HS. And so it's nice for the dermatologist to sort of be the quarterback, work with the surgeons, and make sure that, your HS patients are getting the optimal surgical care, and you're sort of involved in making sure your surgeon is doing the best practices, second intention healing if they will. But sometimes in the bigger cases, they'd like to do a flap or a graft. Mm-hmm. And I think that's a really important point, is knowing when surgery needs to be brought into the picture. And so a lot of times I ask patients, are you getting new spots? If they're not getting new spots and it's only old spots that are still draining or swelling and going down, those typically need surgery. The tissue's already been remodeled. Right now, the medications we have don't really do a great job of attacking the tunnels and getting them to dry up. Sometimes they do, but often that's what you see, is the patient's not getting new spots and it's just their old ones bothering them. And you got to target those ones with surgery. And then you continue the medications and the patient's under really good control.
I have had similar experience with collaborating with, we actually at Pittsburgh, we have a group of plastic surgeons who have started doing more HS surgery. So I think we need to just build more on that. But I know that you guys have pioneered it. Even the technique itself, like I know you have videos that our listeners can access on the internet. It has been in part of a lot of presentations, and something that you can, if you watch the video, it's actually so much easier to perform these punch de-roofings in clinic. So something that I have attempted to do as well. But I think if anybody's interested to learn more, understanding that procedure, it's not that complicated. I mean, I was very nervous to do it at first myself, but I watched you at a few different conferences, talk about it, present it, show the videos. That made it so much easier to go ahead with it. So now we've talked a lot about what's going on right now. So obviously my final question for you would be that, looking ahead in 5 years, what's in the pipeline? What do you think will change the most in the way we are managing our patients who are especially not responding adequately to current therapies? So what do you know is coming for this disease for us?
There's a lot of great stuff coming for HS, a lot of trials going on for new drugs, new mechanisms of action, which is really interesting because the inflammation in HS is pretty complicated. Like you were saying earlier, there's neutrophils involved, there's basophils involved, there are mast cells, there are T cells, B cells, and it sort of evolves over the lifespan of the disease where, early on, something like laser hair removal can be really effective because the inflammation is really around the hair follicles. But then once you get the tunnels, they get these tertiary lymphoid structures with just so much inflammation. So it's nice to see new targets in these different pathways. And it'll be really interesting to see which ones sort of pan out for different patients. One good example of that is the IL-23 inhibitors couldn't really beat the placebo in their trials. But then John Frew, who's a super smart HS guy out of Australia, did a sub-analysis and found that they seem to work in males, but not females, because testosterone actually influences your IL-23 production. Huh. Yeah, kind of an interesting one. The other thing I'm really excited for is dual target therapy. We're seeing this sort of emerge in the inflammatory bowel disease space. And we actually have our first HS trial that's going to have a dual target with OX40 ligand and TNF alpha. And so I think that's going to be really interesting because, like we said, a lot of times you get a partial response from a biologic, And you'd love to put the patient on 2 biologics, but you're really not going to get the insurance to agree to that. So these new therapies, right? Yeah. That have 2 targets are the way that we might actually be able to get this combination therapy for patients and get them under much better control.
Yep. Let's hope we get some good data from these studies. I know with atopic dermatitis, some of these combinations did not do as well as that was anticipated. And I'm really hoping that that's not the case here and we can get some really much better evolved drugs for our patients. And also, I think there's a lot of learning happening on the side that is beyond medical therapy. I think there's a lot of other resources and support groups and information in general for care of the wounds that is growing significantly, which is for another day, and we can keep talking about that. But Steve, thank you so much for sharing your insights. The message that I keep coming back to is that treatment plateau, it does not necessarily mean treatment failure. And that there are so many more options available that our patients and clinicians realize right now. So thank you for being here with us and talking about your, all the expertise you have in HS and sharing the top-notch information.
My pleasure. Happy to talk HS anytime.
We hope you learned a lot from this episode of The Blend. Thank you for listening.